Okay, for our last speaker, we have Gregory Daniel, who's the Deputy Director at the Duke-Margolis Center, where he works on policy and looking at pharmaceutical, medical device related issues to include AMR.
Great, thank you. Good morning, everyone. It's a pleasure to be with you today. And we're in Washington, so we can't go too long without talking about policy and healthcare reform. So I'll do that with you today, if you don't mind, because it's really important here. So I'm not going to spend too much time. Over the course of the last 2 days, you spent a lot of time talking about, and you well know the challenges of antibiotic use and the link to resistance. Specifically focusing on the human drug pipeline, it's very thin. There are very few products in the pipeline right now. Pew Charitable Trust did a study a couple years back with found 41 antibiotics in some phase of clinical testing, and that might sound like a lot if you don't know that it's really there's extremely low probability in any drug class for drugs to get to market. So of that 41, we would only expect a couple of antibiotics to actually make it to market, and it's unlikely that any of those would really have efficacy against our most concerning multi-drug resistant type infections. Just to compare, that 41 still sounds like a lot, geez. At the same time, there are 836 drugs in some phase of clinical development for cancer. And then, so a few of those would actually make it to market. So 41 is actually a very small number. And so the question is, why is that? We've seen a lot of large pharmaceutical companies moving out of the space of developing antibiotics. The market just isn't there for positive net present values or returns for developing antibiotics. So one of those reasons is that we largely across the world, and especially in the United States, we have a fee-for-service way of reimbursing for antibiotics. So the revenue comes in. The more antibiotics that get used, the more revenue the company makes. But with appropriate stewardship, what happens when the brand new drugs are on the market is that we have limited use of those new drugs, and so sales volumes are really low, and the revenue isn't coming in. The additional thing, as was pointed out in the previous presentation, we have a lack of diagnostic tools for treating infections, and so oftentimes when a severe patient is brought into either has an encounter in the emergency department or urgent care center, empiric treatment of broad-spectrum antibiotic is used because there just aren't available appropriate rapid diagnostics, and they take too long to get the results. So this does contribute to sort of more broader spectrum antibiotic use where it's unnecessary. We also have a strong generic market. So there are generic antibiotics that are on the market. They're still very effective against the majority of infections, and so those generally will get used, limiting the opportunities for using the brand new antibiotic, and they're limited to only the cases where there is resistance or there are no other therapeutic agents. So all of this is that low utilization, very slow uptake, and low revenues. And one final point, I think is the most important point, is that reimbursement for antibiotics generally almost always does not reflect the public health benefit that the antibiotics bring to society. So for antibiotics that are on the market, who pays for them? The patients who actually take the antibiotics pay for them either through out-of-pocket or through their insurance company. But the patient, the people, all of us in the room or other patients who aren't taking antibiotics, we're the ones that really benefit from having effective antibiotics on the market. They enable surgeons to do high-risk implantation surgeries or other very invasive medical interventions, because we know that if an infection were to develop, there is an antibiotic that would help treat that. And as well as having appropriate use and available effective antibiotics helps prevent the spread of rampant infections that are multi-drug resistant. So all of this to say is that we really do need to look at how we're reimbursing antibiotics and how we're incentivizing their development. Okay, so there's a lot of information on this slide, so I'll just go through some of it very quickly. There have been some efforts in the United States in terms of legislative activity to help address the sort of push and pull economic incentives to stimulate more interest in investors and in companies for doing R&D and developing antibiotics. The GAIN Act, which was passed in 2012, effectively adds a few additional years of patent exclusivity, which seems to be very helpful, although as I mentioned, they're very low use in the first, once a brand new drug is on the market, due to appropriate stewardship and limiting the use. So extending the patent by a couple years really doesn't change significantly the revenues that would come into the market, and it's still we still end up with reimbursing antibiotics based on volume. So we want more volume use to get more revenue, which is actually what we don't want. The 21st Century Cures Act had the limited population antibacterial drug development pathway, similar to what Dr. Barron suggested towards the end of her presentation. This is a pathway, but just for antibiotics, where we have a much narrower indication, so the clinical trials will be smaller and shorter, and we can get the product on the market sooner, so that does give some incentives, but doesn't at all affect the way that antibiotics are used or reimbursed. And then there were a few other proposals for adding additional Medicare payments for antibiotics used in the hospital setting, and then some ideas on how to implement some economic incentives on the pool side, which I'll go into. I won't go through now, but I will in a few subsequent slides. And then other efforts outside of the legislative activity in the U.S. have been the White House released in 2014 a national strategy on combating antibiotic-resistant bacteria. From that, the President's Advisory Council on Combating Antibiotic-Resistant Bacteria, or PACCARB, was formed in 2015 to address the concerns about low returns on investment, and recommended a combination of general and targeted incentives that can help address these issues, and the creation of CARB-X, which is a public-private partnership designed to provide significant R&D funding in very early stages of development. So as I talk about these, I thought it would be helpful to look at what we mean really when we say push and pull incentives. So push incentives are providing financial incentives during clinical development, or help stimulate R&D and get activity going. Pull incentives are more on, once you have a product approved, what is the market like? What are the certainties in place that the products will get used and that there will be significant revenue coming in from those? And I would say, at least in the U.S., we've had more activity on the push side, which is great. We absolutely need that, but without effective pull incentives, it's like running into a brick wall, where you got great activity in clinical development phases 1 and 2. But who's going to help that product get through phase 3 trials and into marketing? And not a lot of companies are standing up to do that without significant pull incentives. Some of the ideas are, like I mentioned, the add-on payments, extending market exclusivity, which has positive but maybe limited effect compared to what we actually need. And one of the most promising ideas is at the very top, which is delinking reimbursement from volume use. As I mentioned at the beginning, so a big challenge of fee-for-service reimbursement is that more revenue comes in, the more a product gets used, and that's, we actually don't want to encourage more and more antibiotic use. We want to encourage sustainable, appropriate use. And so the idea, a lot of groups outside of the U.S. Have really looked at this. The Chatham House, Drive AB, the Review on Antimicrobial Resistance, the German Global Union for Antibiotic Research Development. All of these efforts are multi-organizational efforts that have looked at these issues, and they all have tended to align on a fundamental principle, which is the concept of delinking revenues for an antibiotics, delinking that from the volume use. So the revenues are there regardless of how often the antibiotic gets used. It could never get used and actually be preserved on the shelf or used very rarely in cases where you absolutely need it, but that concept has nothing to do with the revenue that the company gets. So how would you implement something like that? So the market entry reward is the way to do that, and this figure is a pretty simplistic way to describe this, where on the sort of slope on the left that goes below the line, those reflect the R&D investment costs Once the line gets up to the slope gets up to the line, that's a market approval. So once a drug gets to market, if it's a drug that treats our most serious and urgent infections, successfully gets through clinical development, that company actually either gets a lump sum or gets some, yearly payments over 5 or 6 years that in aggregate result in a positive net present value. So, the kinds of numbers that have been tossed around is somewhere between $1 billion or $2 billion is what a company would actually need in terms of certainty to get to a positive net present value. Okay, so a lot of groups have looked at that, and most of the focus in those activities have been outside the U.S. So the Duke-Margolis Center, which is based here in Washington, D.C., as well as on campus at Duke in Durham, North Carolina, took on a project, and the project was simple. It was look at these economic pool incentives that all of these great groups have been talking about and try to figure out what might make sense for the U.S., what could be implemented into the U.S. healthcare system, a system where we have many private payers, the Medicare program, Medicaid program, and very challenging ways to implement reimbursement reform or a delinkage model and how a market entry reward might look. So with partial support from the US FDA, as well as a grant from Merck, we spent the better part of a year and a half with a senior expert advisory group that included payers, private and public, patient groups, infectious disease physicians, societies, and manufacturers themselves to sort of get around a table and talk through these things and to talk through what might practically get implemented into the US. And so early on in that effort, we came up with our core principles for guiding any successful economic pool incentive that could be implemented into the US. And here they are. Number one is that no pool incentive by itself is going to be the silver bullet. This really will need to be a combination of push and pull incentives. Any economic pool incentive should promote and reward innovation, should promote stewardship, and promote access. And so so in addition to that, in terms of thinking through like a market entry reward, which generally you would think like lump sum that $1 billion or $2 billion, where does that money come from? Generally, it will need to come from the federal government, so the public sources of funding. But in the U.S., that's very challenging to get the Congress to do that, and public funding to pay for drugs is something that may not necessarily get through both the House and Senate and across the Democrats and Republicans. So we think a key combination is maybe reduce the need for public funding by leveraging that with private funding. And I'm going to talk very specifically about what I mean for that. The final three principles are, in a way to promote reward innovation, companies really need rapid access to funds upon market entry. They need certainty that if their drug gets to market and it treats one of these very urgent infections, that there will be revenue upon market entry. And that the sources of funding need to be sustainable and dependable and align with the broader shifts across the U.S. So the U.S. healthcare system is moving away from fee-for-service more generally as we talk about episode-based payments and bundled payments and accountable care organizations, all providing incentives to reduce or curb costs, but strong incentives to make sure that patients are getting the care that they need, that the quality and patient outcomes are highly incentivized. The thing that's not on here that I do want to emphasize is that anything that works in the U.S. might need to be slightly tailored for the U.S. healthcare system, but should complement and align with global efforts. So as one type of market entry reward might get implemented in Europe or in other countries, it doesn't need to be exactly the same in the U.S., but anything in the U.S. should complement and align well with that. Okay, so this is just, if you don't already know, as I mentioned, the U.S. healthcare system and many healthcare systems outside of the U.S. are trying to move away from volume-based fee-for-service, where physicians and hospitals get paid more and more for more services and more intense services, rather than getting paid more and more for delivering better outcomes and quality for patients. So we have ways of implementing this through alternative payment models that I mentioned before, like bundled and episode-based payments. These are payments that are tied to results, measured results. So it's not just about controlling costs or reducing costs. It really is about ensuring that we have better outcomes for patients. And this broader shift does create a new opportunity for how we think about incentivizing drug antibiotic use. And it's hard to think of any other therapeutic area where you want to reward innovation or ensure that we're getting better outcomes while also limiting the use of the drug. And so this does create a really good opportunity for antibacterial drugs. So we actually came up with a new model that is a form of a market entry reward. I would call it sort of partial delinkage, which includes a combination of a market entry reward with value-based payments. So essentially what happens if you think about that figure that I had before, where the market entry reward might get paid out to the company over a series of 5 or 6 years, this is similar to that. However, the market entry reward will phase down over time, so the company actually weans off of the market entry reward, and continued payments are dependent upon a couple of different things. Availability of the drug, so that it's there if providers and health systems need it. Continued sensitivity of priority organizations, continued activity towards those infections. That there are some tracking and reporting of appropriate prescribing, as well as continued collection of post-market data to understand how the products are getting used and to continue to learn about their effectiveness. So together, the pay-award model resolves that conflict between the drivers of return on investment with strong stewardship, so the company gets their revenue regardless of how often the drug is used, but the revenue is tied to some of these fundamental important things in delivering better access to drugs to patients. So one thing that, I'll show on the next slide exactly what I mean about this phasing down and where the value-based payments are coming, which I'll actually do now. So the HHS, Department of Health and Human Services in the United States, came up with the Healthcare Payment Learning and Action Network, which really looks at, and this is the group that sort of designs what fundamental alternative payment models look like. So they came up with this sort of four categories of payment models. Category 1 are the traditional fee-for-service, where there are no links to quality and value. That's just the more you do, the more money that gets paid to the provider or the health system. And it gradually moves up into more population and quality-based payments. Category 2 is sort of an incremental step where you actually still do fee-for-service, but there are additional incentives that are linked to outcomes, but still on the fee-for-service architecture. Category 3 takes an even additional step, and that's where we're talking about more bundled payments, where there could be some upside and downside game sharing, but still we're talking about a fee-for-service architecture that definitely have quality incentives. And then category 4 is a truly population-based per member per month payment that goes to providers to provide overall care for their patient population. So what we did was to take this sort of framework and think about, well, if we were reforming the way antibiotics get reimbursed, how would this, where in this framework would we be talking about? And so we're really talking about category 3 and 4. For antibiotics, the payment, and now we're talking about payment to the manufacturers, might be episode-based or per member, partly per member per month, but partly episode-based payments that go to the manufacturer. The manufacturer can still get fee-for-service revenues, but the majority of the payment to the manufacturer is based on some of the alternative payment models. And then category 4 would be where private payers pay a fixed per member per month back to the company, so it's spread across their entire membership regardless of how often the drug gets used. So this is the slide that really describes this model. On the left is reflecting the sort of first 5 years that a drug is on the market. The blue is the market entry reward. So those would be the federal dollars or some other public source of funding that go out to the company. And as you can see in year one, it's really high. The majority of the revenue back to that pharmaceutical company comes from the market entry reward. But each year that goes on, it phases down rather drastically. And the payments in year 2, 3, 4, and 5 are dependent upon that company demonstrating that it is increasing its revenue with these alternative payment models from the private side. So the private funding is reflected with the green and the yellow. So green is the traditional fee for service. So it's intended to be, in year 2 and 3, if the company is doing a good job of getting into more value-based payments with payers, but they're not quite there in terms of the size of those payments, or it's just sort of taking a few more years to take off. The company is, could do the traditional fee-for-service selling of how drugs get reimbursed today, and that's okay because when you get to year 3, 4, and 5, those payments from the blue are going to be tied to increasing demonstration of value-based payments, the yellow. So by the time we get to year 5, the company would have 75 to 80% of its revenue coming in from the value-based payments, and then year 6 you might see more like 80 to 90%. And so once we get there, that is full delinkage. All of the revenue going back to that company is borne by the private sector. And is dependent upon the volume or is dependent upon population sizes that are covered by these payers, not dependent upon how often patients are using the drug. And so these alternative payment model contracts that the private payers would enter with these companies would be tied to, is that when we need the drug, is it available? So the companies have a strong incentive to maintain their healthy supply chain. Are there continued data collection so we can better understand across the U.S. how these drugs are being used and in what cases are they being used? And are we continuing to collect data? Do they continue to work? Are they continuing to be effective treatments for these things? So I'm out of time. That's all I have. It was just a next slide on how that sort of blue part gets funded, but we might get to that in the Q&A. So thank you.